Thank y'all. I know it's a really kind of nasty day out there today. We have one more member. I think Representative Gardner will be here with us. Our two committee members had things come up and will not be here. And we are making sure that they get all the information always at each of these meetings, though. So even though there may be two of us right now, hopefully three in a few minutes, we're all listening and ready to, whoops, just watching the door, ready to address this great challenge that we've been in conversation about. So we will start off this morning, the House Study Committee on Children's Mental Health, and this is our third meeting. Our first presenter is Diane Kelly and Debra Johnson, I believe, from the Division of Family and Children's Services, Department of Human Services. And if y'all would like, you can sit here at the table. That's comfortable, hopefully. Yeah, pull it close so we can get it all. Thank you.
Okay. Good morning, Madam Chair and Honorable Representative of the Study Committee. My name is Diane Kelly, and I'm the Foster Care Services Director for the Georgia Division of Family and Children's Services. And I'm joined today by the Department of Human Services Medical Director, Dr. Debra Johnson. And we are here today on behalf of the Division Director, Bobby Cagle, and the DHS Commissioner, Robin Crittenden. We appreciate the opportunity to address this committee as you study this very critical and relevant area of our child welfare practice, children's mental health services. Dr. Johnson and I will make our comments in brief and then certainly answer any questions that you have. The division is not a clinical service provider, but with 11,832 children in our care, custody, and oversight as of Friday evening, we're probably the largest parent in the state seeking services for our children. As is the unfortunate norm for children in the child welfare system across the country, children in defects care are at an extremely high risk for experiencing mental health issues. When compared with the general child population, children in foster care and those who age out of foster care experience higher rates of mental health distress and disorders. Children that are in foster care that have mental health disorders are harder to find permanency for, that is to get them out of foster care, and it's also difficult to help them to find stable placements in foster care. And this is reflected in our placement operations, where 1 in 5 children are considered either additional or maximum watchful oversight. And in additional and maximum watchful oversight, what that means is that these children have moderate to severe behavioral, mental health, or medical challenges. Additionally, we have currently about 144 children that are placed in psychiatric residential treatment facilities, or PRTFs. So because of the high prevalence of mental health issues among children and youth in foster care, our child welfare practice is aligned to really address and to meet those children's needs. And so I want to highlight 6 areas of our practice that are most relevant to meeting those challenges. To begin, first, when children enter the foster care system, a comprehensive psychosocial assessment is conducted, which includes looking at their medical and dental and educational well-being, but it also includes a trauma assessment. And that trauma assessment, which is conducted by therapists, clinicians, Medicaid-funded clinicians, is really our entry point to looking at children's mental health status to determine whether or not they're going to need additional screenings or more comprehensive psychological workups. Second, we have a very strong partnership with our room board and watchful oversight providers. Our placement providers, RBWO providers, actually serve the vast majority of our children and youth that have the medical and mental health challenges. Although we do not have a placement system where clinical services are bundled with the therapeutic services, our RBWO providers are typically the ones that spearhead procuring clinical services for these children. And in addition, many of our RBWO providers are also clinicians and have separate businesses that are provide the therapy for these children. Third, DFACS has a very strong and positive partnership with the Mayor Group, the CMO, DBHDD, and DCH. And this is very evident in how quickly we can assemble around individual cases to staff children where all the departments are needed, as well as how we come together to tackle systemic issues. The fourth area is our new placement resource operations team, which is a state office function that works with the county departments in serving children with high-end mental health concerns. So the PRO team, as we call it, helps the counties with identifying appropriate placements, facilitating the entries and exits into PRTFs and the crisis stabilization units, for example. The fifth area that I want to highlight is a new program called TAC, or Training for Adoption Competency. We have about 900 adoptions that are finalized annually out of the foster care system. And there's also a national trend where private adoptions, private international adoptions, are dissolving at a higher rate than has been in the past. And so we've recognized the need to make sure that we have adoption competent therapists throughout the state. And so DFACS applied to be a TAC site, and we were given approval for that. And so starting in December, we'll have our first training program for training clinicians who want to work with adopted children and their families so that they can have more competency and skill in that area. The last area of our practice that I want to speak to, and then I'll let Dr. Johnson take over, is our psychotropic medication management protocol. This protocol was instituted in 2013, and our goal is to ensure that our children in care are not improperly or over-medicated, as has been a nationwide trend. The protocol, among other things, requires that the county director or designee sign off on any psychotropic medication prescriptions for children in care. And so now I'll let Dr. Johnson talk about some other efforts supporting that initiative.
Good morning, Madam Chair and committee members. Again, my name is Debra S. Johnson, MD, and some of my credentials are: I am a diplomate of the American Board of Psychiatry and Neurology in General Psychiatry, and I'm also a diplomate of the American Board of Psychiatry and Neurology for Child and Adolescent Psychiatry. I have practiced both adult psychiatry and specialized in child psychiatry, including residency and fellowship, for the past 20 years. As Ms. Kelly mentioned, I came on board with the Department of Human Services to serve as medical director in January of 2015. As the medical director for the Department of Human Services, I have continued a program of psychotropic medication reviews for the Division of Family and Children's Services. Typically, children who have severe mental health disorders and are prescribed multiple medications are referred to the Office of the Medical Director for medical review. Over the past 10 months, I have consulted on more than 150 medication reviews. Medication reviews typically involve reviewing all mental health records, including psychiatric evaluations and psychological evaluations. These also include reviewing a child's previous medication history and may include a consultation with the prescribing physician. More complex cases may require a roundtable of DFACS leadership, state leadership and staff, the prescribing doctor, other clinical staff, and also the Office of the Medical Director. Prescribing practices are fully explained by the practitioner, and appropriate therapeutic services are also advocated for the children that are in our custody. Since I have joined the agency, the Office of the Medical Director has also initiated psychopharmacology rounds for DFACS. Approximately once monthly, we now hold these psychopharmacology rounds. And psychopharmacology is basically medications that are prescribed for psychiatric purposes, so it's called psychopharmacology. And so these rounds are held to allow DFACS staff to privately discuss cases and medication concerns. Another initiative of the Office of the Medical Director is to provide training in mental health for DFACS staff. Approximately 4 mental health webinars have been completed, such as psychosis in children, and psychosis means being out of touch with reality, which may include a diagnosis such as schizophrenia. So psychosis in children and bipolar disorder in children. These webinars are very important to train DFAC staff to recognize mental illness and make appropriate interventions as necessary for children in custody. Next, as medical director, the Office of the Medical Director has also collaborated with the medical director of the statewide CMO for foster care, AmeriGroup, to ensure children who are in psychiatric residential treatment facilities receive appropriate care and to oversee transfers to other facilities or discharges home. Also, the Office of the Medical Director, DFACS, AmeriGroup, and the Department of Community Health have also collaborated to ensure adequate access and appropriate referrals for psychological evaluations. Reviews of psychological requests and improvement of review protocols of psychological requests were completed. Now, currently, over 80% of psychological testing requests are approved for our children that are in custody. The Office of the Medical Director is also a committee member of many behavioral health committees, such as the Cold Case Coaching Project. And the Cold Case Coaching Project is a project designed to help children who have been in foster care for an extended period of time. So the entire team is actually looking at children who have been in custody sometimes as long as 2 years to see what other interventions can be done to help get those children out of custody and into an adoptive family home. There is also the Interagency Directors Team meeting, which is a committee meeting of various state offices such as DBHDD, DJJ, Department of Education. And so we're just looking at how we can help improve mental health across the state of Georgia. There's also a Georgia Child Advocacy Council, and this Georgia Child Advocacy Council is tasked with helping to get more providers that are specialized in child sexual abuse. And then I also serve on the Oversight Committee for Georgia Families 360. It is important to serve on these committees and advocate for appropriate mental health interventions for children in foster care. And then lastly, I also co-chair along with DFAC's Deputy Director, Virginia Pryor, a medical provider network initiative. And this is an idea of DFAC's Director, Bobby Cagle, and he has tasked us with developing a specialty outpatient network of child physical and sexual abuse providers throughout the state of Georgia. The goal is to have these specialty providers in place throughout the state so that children will have appropriate access to these specialized intervention services. Thank you very much. I will turn it back over to Ms. Diane Kelly.
Okay, thank you. So finally, we'd like to share with the committee 5 areas to consider as it relates to your study of available resources and possible solutions or improvements in the delivery of services specifically for children in foster care. The first area that we'd ask that you consider is that the fact that we no longer have therapeutic foster care in Georgia. Around 2007, the Centers for Medical and Medicaid Services, or CMS, mandated that Georgia eliminate its bundled therapeutic services, or which was called level of care. In a bundled system, the per diem rate contains costs charged for the room, board, and watchful oversight, as well as the clinical services. And so in an unbundled state, which we are one of 5 that are unbundled, the room, board, and watchful oversight is separated from the clinical services. And so, as I stated earlier, many of the children in our system require mental health services, and particularly for those children that require higher end services, the additional and the maximum watchful oversight services, having a community therapist is just simply not enough to actually help them to get better. And so they really need a holistic program that has the therapeutic milieu a part of their living situation. As a side note, the Governor's Council Child Welfare Reform Council has also taken similar note of this issue and has asked DFACS to look at developing standards for therapeutic foster care providers. The second area for consideration is also related to the unbundling as well as going to a CMO. Under the bundled services that we previously had, the PRTFs, or the psychiatric residential treatment facilities, were a part of that level of care system. They were considered level 6 providers. And although we still had to make an application for admission to have children admitted, there was a more seamless process between the placement providers, the RBWO, the lower levels, and the PRTF. And so now that we have unbundled as well as gone to a CMO, the PRTFs are completely separate from the room board and watchful oversight providers. Administratively, it can take up to 7 days to get an admissions application approved to have a child go into a PRTF. And so typically, things are happening in real time, and we really don't have 7 days or even 1 day to wait to get a child placed into a PRTF. And so what typically will happen is that DFACS will state fund the stay. We will direct fund that stay rather than going through Medicaid to fund that stay. And so out of the 144 kids that we currently have in PRTFs, we're state funding approximately 19% of those children that are there. I also want to point out that it's not just about entry into the PRTF, but oftentimes once children are ready to step down out of the PRTF, if we don't have a placement available, then we also will have to provide a gap waiver. Once Medicaid stops paying, we still have to be responsible for that payment. So the third area is also related to PRTF stays, and that is we see a clinical continuity of care gap when kids are entering and exiting the PRTFs. And that's because there's not a funding stream for the PRTF therapists and the community therapists to really interact around that child's needs as that child goes into the PRTF or exits the PRTF. So we see that there is a funding gap that exists there. The fourth area is the need for more child and adolescent clinical service providers. That would be clinicians and psychiatrists, particularly in the rural areas. In many of the areas of the state, it's either difficult to get appointments, or we're not able to get the specialized services that we need for specific mental health concerns, or we don't have a real choice in the providers that we can use because there's so few of them. We don't really have choice in who we can actually use. And finally, with the increase in the number of children in care and also exiting or aging out of care that have developmental delays, there is a need for an increase in the number of DD slots that are set aside specifically for children in the foster care system. Any questions?
Thank you. That was an excellent, quick summary of the challenges that we know y'all face every day, and I appreciate your bringing them forward for us to take a serious look at right now, and I'm sure there will be some questions. So let's start with Representative Gardner.
How do we get it to work? Right. Well, EPSDT is the schedule that they need to follow as far as getting their medicals and their dentals completed, and that's a part of our requirements for our caseworkers as well as our RBWO providers. Our RBWO providers in particular are scored with their performance-based placement quarterly scorecards about how well they are helping us to get those EPSDTs done. But it is an expectation that our children are getting and staying on that EPSDT schedule.
I hear that people tell me that it's underutilized or inappropriately used, and I'm just trying to figure out why. I mean, it is federal law that requires certain things. I mean, is it the payment schedule? Is it their barriers? Is it that there aren't providers? Maybe all of those. But what would you say are the most problematic? They need an evaluation. If they need medical treatment, we're required to provide it.
Right, right. Well, I'm not sure I have the answer to your question. What I can say is that EPSDT is the standard schedule for your annual physical and your dental checkup. So it doesn't really go into the critical care treatment part of medical service provision. So it is our expectation that our kids are staying on schedule for the medicals and the dentals, and they're, to my understanding, I'm not aware of any challenges that we've had with keeping up with the EPSDT schedule. I have some folks here with me from DFAC, so let me see if someone can answer that.
Yes, good morning. I'm Kristen Tolliver. So what we have in place, we are working with our CMO Amira group, and to cut down on some of the issues that you're talking about as far as getting them done timely within 10 days of entering into care. Amira group is scheduling their initial appointments, and one initiative that we have in DeKalb and Fulton County is to make sure that medical vans are on site. And what consists in those medical vans is a provider that will do the medical checks as well as your health checks, and then a provider that is inside the DFAC's office to do the trauma assessments. So that will cut down on the timeliness of those EPSDTs. As far as the ongoing, DFAC's has created a new team, which is WEPAC, to go into the counties to see why those haven't been done. If they haven't, then again, getting with the Amira Group Care Coordinator to ensure those as well are getting done timely and following any recommendations, as if a child has a cavity or needs a root canal, to go deeper and looking into that.
So when she was talking about one of her priorities was continuity of care, is the care manager function that is not funded that keeps the EPSDT from working?
Well, my comments were really about mental health care, so the therapists they're not being a funding source for therapists, the clinical therapists, to convene. Once a child goes into the PRTF, the funding goes to the PRTF to provide the therapeutic services, and the
EPSDT does include mental health services, does it not?
I don't believe that the schedule includes mental health.
It does.
It does.
Absolutely.
Okay.
It does.
Okay.
Yeah, so anyway, it's something I would really like to explore with you, because maybe you're missing an opportunity for diagnosis and perhaps.
Okay.
Just a comment, and then I have a question. It is concerning to me that kids in crisis might take up to 7 days for those kids to get the help that they need. If you would elaborate, I would appreciate it. What do we need to do to lessen that so those kids can get help immediately when they're in crisis?
Are you saying when they come into care?
Yes. I think you mentioned that sometimes it took up to 7 days for them to be able to get the help that they needed.
Well, we make sure that they get the help that they need immediately, even if that means state funding a
yes,
state.
I heard that.
I believe it's really related to the fact that we're unbundled, and we don't have a step-down level of care for children who are in between what an RBWO placement provider can provide and what a PRTF can provide. So there is this gap for a treatment provider that is greater than maximum, but perhaps less than a PRTF. And so because we don't have that type of service provider in this current continuum, we have to jump from maximum watchful oversight to a PRTF, and we have to do it immediately.
Okay.
So
I'm sure that's very taxing, though, for you all when those crises come, but
Correct.
I'm glad you do respond. And then, Dr. Johnson, might I ask you to elaborate a little bit more on the psych evaluations that you said were available? Are these available statewide?
I was indicating psychological evaluations, and there had been an issue about our children in custody and just children in general with Medicaid receiving psychological evaluations. And so the Office of the Medical Director, along with DCH, of course, and Department of Community Health and Amira Group, we worked together in a work project to look at the process with psychological evaluations. And so a process came by where now over 80% of the psychological evaluations are approved. and those rates increase from very low rates where it may have only been 20% approved, starting in May of 2015.
Wow,
Okay.
that's a big change.
It really is.
Yes, it was.
Thank you.
That is quite a change, and I thank you for that. That collaboration seems to be working, so we'll hope you'll continue to make that even stronger. I had a question back here. The TAC team, the Training for Adoption competency, you know, I think much of what that is doing is excellent, it sounds like. But we also have that foster family that is there just for a crisis. What are some of the things that are being done right now to support and help those foster families who receive a child with with an open heart and the best of intentions, but sounds like at times often the family is not prepared for what might be coming in, and the child is certainly being further traumatized quite by accident.
Well, a new initiative, I guess I could have also mentioned, we have just entered into or are entering into a contract with Children's Healthcare of Atlanta to do trauma-informed training for our staff who support foster and adoptive families, to train them on trauma-informed foster care principles and how to support foster families, as well as they're going to be training some of our group homes on trauma-informed care, so that the foster parents, as you say, they're going to be the ones that are on the front lines, and they're going to need to know how to really address and manage and respond to children's mental health needs, behavioral needs, and they need to do it in a trauma-informed way so that they're not adding additional trauma. And then foster parents also just need support around what to do. We're establishing a warm line so that foster parents, they're not in crisis, but they just need someone to talk to. We're going to staff that warm line with current foster and adoptive parents so that parents have somebody they can just reach out and talk to and get some ideas from. But in general, foster parents receive at least monthly contacts. Generally with our RBWO providers, it's probably more weekly or every other week because they are managing the kids that have a little bit higher needs. So there's a lot of face-to-face contact with them. They have training that they take part in on an annual basis, 15 hours of training a year that they have to do. We have upcoming in February the AFPAD conference, which is our Adoptive and Foster Parent Association of Georgia. We're going to be sponsoring about 450 foster, adoptive, and relative caregivers to go to that training so that, again, they can get some of the skills and the support that they need to be able to manage.
Just from what I'm hearing, I really think that is so very important, because I hear from a lot of foster parents that are frustrated with the situation and the ability to contact. When will that line be live, that warm line?
I would estimate the spring.
Okay.
We're in the process now of hiring staff to staff the caregiver recruitment and retention unit at the state office. We're blessed to have some funding to actually do that now. And so once that team is up and running, we'll be able to start adding in some of those supportive services, including that warm line. So I would estimate the spring.
Good, good. That's great. Thank you. Representative Chen.
I too applaud you for starting that. That is much needed. And not to put you on the spot, but as you were sharing, it reminded me of this. This weekend, I had a conversation with a foster parent who was very concerned because she did not feel that she was given all the information that she needed. And she felt that she could have better responded to the child's needs had she known everything. Will this line be able to assist with that when it is in place?
Well, certainly it will be a vehicle for her to surface her concerns if she can't get it resolved at the county level, because that line will be overseen by someone from the state office, and so that's definitely going to be a vehicle. But Commissioner or Division Director Cagle has also noted that this is a concern as he's been out on his road shows, that foster parents are not being given the information about children, as well as our RBWO providers also are not perceived to not be given complete information about the children that they're caring for. And so he actually has a memo coming out to staff. It's probably ready for him to send out now regarding the need to make sure that we are fully informing our caregivers about our kids. The memo actually includes specific components of the law that will help a caseworker to understand what you can share and what you can't share. Oftentimes, our workers, they're not sure, well, what can I tell, the caregiver, and what shouldn't I tell the caregiver? So we've really tried to outline very clearly the expectation that caregivers are well informed, and giving them a list of clear instructions around how to inform them and what they can share out of the records. Thank you.
Any other questions? You got another one?
Impressed with the trauma-informed care initiative that you've described. That is, the training is being provided by CHOA. I'm trying to understand exactly what you said. So they do training with providers, so with the case managers?
There is a training that was developed by the National Child Traumatic Stress Network. I believe they're out of California. And CHOA has become a trainer of that curriculum. And so they approached us about cascading that training to our caregivers, but doing it through our resource development workers. Our resource development workers are the ones that recruit and train and support our foster caregivers. And so we felt that we could get a broader reach to really reach our foster caregivers if we train the resource development teams so that they could then support their families. So the training that CHOA will do will be to the resource development workers. We are also doing a pilot, and that would be to have them train some select CCI or group homes in the metro Atlanta area, just to kind of see how it would work. And then there'll also be a couple of foster parents that they'll also train, and they'll kind of be co-trainers with the resource development team. So we're really looking forward to that.
And are they the sole providers? I mean, then where does the referral go?
The referral?
For the kind of intensive therapy that someone that's traumatized.
It's not therapy. This is really about having a therapeutic foster care or trauma-informed foster care practice. And so the resource development workers will then have the knowledge to go out and do workshops with the foster parents and really kind of infuse this trauma-informed thinking with all their interactions and how they help the foster parents to manage and recognize when a child is not just acting out, they're acting because they've been traumatized, and this is the best way to respond to that.
So the parents then are expected to provide the almost clinical services, are they? Or tell me about how I'm trying to follow the process to getting the kid the real help that they
right. Children
in addition
absolutely
to the parents.
Still need to have a clinician involved, a therapist involved. But as I was speaking about the need for there to be a therapeutic element to the home environment, whether that's a group home or a foster home. And so this is what the trauma-informed training will do. It will just add that more therapeutic environment. The foster parent is not the therapist, but there's ways to be more therapeutic in how you respond to children.
Well, I think that's a great development. I just worry about the limited resources beyond CHOA.
Right.
That there are other providers out in the community. We need them. Thank you.
Sure.
Well, that looks like all of our questions. I thank you. I
Thank you.
applaud your effort.
Thank you.
I know you have some huge challenges, but we are doing all we can to try to help you address those. And
Thank you.
just thank you for it, and thank you for the information.
Thank you.
Our next presenter is Dawn Randolph, the president of DIR Consulting Group. And Dawn, if you want to tell us a little bit about yourself when we start up here as well.
Good morning, ladies.
Good morning.
Good morning. I am Dawn Randolph, and I have a little consulting business that I do public policy work for nonprofits and organizations such as the Georgia Council on Substance Abuse, which I'm here representing today. I am their director of consultant on public policy, and I was one of the founding executives of the council back in the day, in 2000, when we got together and thought we really needed to look more closely at substance use issues for youth and adult. And so we founded the Georgia Council on Substance Abuse by bringing together a collaboration of several folks looking at policy and practice and professionals. So I'm here today to talk about substance use disorders in youth and a screening tool called SBIRT. And Representative Gardner brought up something very important about PTSD and how we can, move into more of a preventive public health approach. And I know that Representative Chandler, with your school counselors committee, you're looking at ways to work with kids. So what I'm bringing to you today is a tool called SBIRT, Screening, Brief Intervention, and Referral to Treatment. And as I get a little bit more into it, you'll find out what the nuances is and how it crosswalks into a lot what we're doing with kids and mental illness. Because many times we've got kids who are both involved in substance use disorders and who have a mental illness. And how can we figure out ways to get them the resources that they need? So and ask questions along the way. This I hope will be interactive. One of the things that I want to bring to your attention is that we've got this large population of people, and everybody's thinking, substance use is in the news right now. We've got a lot of opiate issues, heroin use, a lot of kids dying, a lot of kids overdosing, a lot of prescription drugs that are being abused. However, what we know is we've got harmful users, and then we've got the untreated, and that is about 8%, and that's what we've got to dig into, is how do we get that 8% of folks that don't get treatment to get the resources that they need. And what we want to see is that every kid in Georgia, every teenager has a shot at a really bright future. And when we're talking about kids, we're going all the way down to the age of 10 and 11 and 12. We can't get them early enough because their futures are in jeopardy once they start using or misusing alcohol and drugs. They've got some data here and a great handout that I gave Roma that you can look at your leisure that has a lot of the data in it. It really talks about, kids age 12 start seeing use 7 million kids. And that's more than kids would have with heart conditions or diabetes or cancer. 1/3 of all inpatient hospital costs are linked to addiction and substance use. And 9 out of 10 people with addiction started using before they turned 18. I'll get back to that fact a second. Again, addiction very rooted when kids start using. Also, we're seeing that people with a drug dependency are dying an average of 22 and a half years earlier than the general population. Not a very good actuarial fact there that we're seeing happen. So I want to go back to that. Again, 90% of adults started using before they were 18, and half of that before they were 15. So we've got kids in the system, children with mental illness, that we really need to figure out what's going on with them. Nearly 1 out of every 5 high school students in Georgia reported drinking more than just a few sips of alcohol before they were 13. And adults who begin talking with kids about this notice that they can help reduce their use down the line. We're also seeing heroin use among teens and adults really start to ratchet up. It's a scary, scary thought. Heroin is a really scary drug. And every year it seems like, okay, we're dealing with methamphetamines or we're dealing with cocaine. And every year something comes up that's really epidemic, and right now it's heroin. This is another great way to look at it, and it's a great little chart that shows, again, addiction. Age of first use, 28% before the age of 15 adults report having an addiction. First use before 15 to 17, 19%. First use 18 to 27%. First use 21 or older, 4%. You know, it's interesting that we in our public policy has 21 as our demarcation of saying that you are legal now to have alcohol, and that's for a very good reason. The brain science says our brains are developing, and 21 is kind of, you know, when things get settled down, and we're seeing that addiction doesn't happen as much for those that are using over the age or have first introductions over the age of 21. So we wanted to really get to those kids, and how we do that is what I'm going to talk about next. Want to give you a little background. We joined together the Georgia Council on Substance Abuse and Georgians for a Healthy Future to look at how we could come up with a preventive public health approach to this situation. What are the tools that we could use? How could we address this? We got a grant from the Hilton Foundation to help us over 3 years look at this. And for the last 2 years, we've been studying it. We've been looking at kids in Georgia and talking. We built a broad coalition, brought nurses and the physician's assistants together, and all the different folks that touch on kids' lives. And what we found is they're not getting screened in their annual checks when they go for the early periodic screening and treatment. There's like, what do we do with that? How, you know, we get our wellness checkups, but what do we do about the health and the behavioral health and the mental health and the substance use? How do we have that dialogue? And so we found a big training gap is out there. So how can we address that? Well, what we're looking at is SBIRT, and it's a multi-dimensional screening that looks at severity of substance uses. It looks at depression and anxiety, ADHD, what's happening in the school, what's happening with their peers, what's happening in a child's life legally that's causing some issues. And this multi-dimensional screening starts with the screening piece. In your packet that I gave you, there's a wonderful policy brief, and it actually has an example on page 6 of a tool that we can use called CRAFT. And CRAFT is this really wonderful few questions that start getting at kids to having a dialogue. And really simple things like, have you ridden in a car with someone that may be using? Maybe you weren't driving, but have you gotten in a car with someone? Do you use drugs or alcohol to relax? Do you use it when you're alone? Do you forget things sometimes if you are using drugs? Do your family or friends want to help you cut down on drinking or drug use? And are you having any trouble in school when you use alcohol or drugs? Those are conversations that we want to have. And when a child screens for use and maybe other issues, then how do we do the next engagement, which is called brief intervention? How do we talk to them about, well, if you're using, you know, what do you think that looks like in your life? How do we sort of look at the high users and the severe users? And then, as Representative Gardner, how do we get them to treatment? And how do we get them to the right treatment? Is it a mental health issue? Is it a substance use issue? Is it a family issue? How do we figure out where they need to go? And you're probably thinking, well, why aren't we doing that now? Why aren't we using screening, brief intervention, and referral treatment? Well, that's because we don't pay for it. There are codes in Medicaid, and there are codes in private insurance, there are CPT codes, that could be used to help reimburse all kind of folks, physicians, school nurses, school counselors, health educators, nurse practitioners, in all kind of settings, in school settings, in emergency room settings, in physicians' offices, everywhere that the kids are. That's where we need to be. So this is a tool that I wanted to put in your toolbox as you're thinking of solutions to getting into children's mental health issues, substance use issues in youth. We have another study committee on the Senate side that Senator Unterman is chairing for mental health and substance use issues in youth, and she's looking also more intently into this. But we want to make sure that you as a committee had this as a potential tool that you could see going forward. One of the things that questions are asking is, well, what about our workforce? Well, we have 13 years of training projects in Georgia. We've had this actually at Grady at the emergency room and down in Macon. Now, those were adults that were being targeted, but we were demonstrating that screening, brief intervention, and referral to treatment actually worked. And what we have had now is over 2,600 students and residents trained, 118 faculty in medicine, nursing, and the physician assistance programs across Georgia. We are seeing that these people that are trained are using brief interventions in their practices. And the opportunity now is to accelerate this by turning on CPT codes so that those folks that are trained can use it and get billed, be able to bill. Let me talk to you about what it looks like when in the two places that we demonstrated it, which was Grady and in Macon. When brief intervention was used, the alcohol consumption went down, drug use went down, marijuana use went down, and cocaine use went down. All of these went down, which is very exciting. There was a control group, and those that had interventions around binge drinking, the ones that received the screening and brief intervention, they went down significantly. I mean, when your researchers think about it, going from 60 to 52%, that's significant. The control group, no change in their behaviors and readmissions to those hospitals. They had some really good research dollars to go and look at folks 6 months follow-up, and they saw a significant difference. Mental health, we see the quality of life go up for those people that were able to get a brief intervention or referral to treatment and get their substance use under control and address their quality and their mental health outlook. So, what do we need to do? Well, to get this tool figured out, what we need to do is to help kids by looking at ways to identify all the different places that they can be screened and look at ways that we can get counseling to them so that we can make sure that their use is controlled or reduced as much as possible. We also know that with kids, they really are little sponges. And when we think about it, we also need to reward those kids that are doing the right thing. This isn't just about, how do we get to those kids that are having issues with mental health and substance use disorders? But what about reaffirming the kids that are doing the right thing and asking them, how are you doing that? How are you working with your peers? And hearing about, well, we're doing proms that don't have alcohol involved. We're carpooling together. We're finding out how to get our friends help. And so looking at that is another great way. Brief intervention also, we're seeing it really does curb. I mean, their use is going down, and it saves lives. You know, one statistic that we're seeing across the entire country, if you invest $4 or $1 in substance use treatment, you get saved $4 in health care and $7 in the criminal justice system. So you're talking a $1 investment in treatment saves $4 in health care and $7 in criminal justice. That's an incredible return on investment that we hope we will be able to help you with by activating these Medicaid codes for SBIRT. We know that over half of Georgians' youth are in Medicaid and Peach Care. So there we can get half of them. We know that Blue Cross Blue Shield is doing SBIRT, and they're trying really hard to make that work. So we would love to give their sister company, AmeriGroup, the opportunity also to use SBIRT in their practice. We know that Medicare is also able to use it. So Medicaid is the gap right now where we don't have the codes turned on yet. We're only one of 12 states that don't have the codes turned on. So there's a map in your little policy brief that show all the states, and also some other studies in your packet from Wisconsin and Colorado that really dive into how we can make a difference here. Probably on the left side of your packet. So the steps that I want to just tell you out really briefly, the codes that we see are the most successful are those CPT codes 99408 and 99409 that look at the screening brief intervention. We know that we need to define the right providers, and a great step is looking at the Medicare guidelines. And then we need to look at where we can deliver this. Emergency departments I mentioned, primary care, and school settings, because that's where the kids are. And finally, being able to start as young as 12, because that's unfortunately where also the kids are starting to use. So I want to stop there, and I can go over anything in your packet, answer hopefully questions, or find a resource for those questions, and give you another tool to help with this very important issue.
do we have any questions from the committee, or everybody want to take just a minute? I think we're looking at all this
I know.
information, which
Lots
is
of
great.
stuff. I've given you a lot of information. And available to sit down. We've got experts. Dr. Paul Seal from Macon just became the president of a national physicians group that will be looking at substance use issues, and he is in residence at Macon. He was part of this expert project. We've got Dr. Aaron Johnson, who's at Augusta University, who has got incredible research, and he just received a SAMHSA grant to do training of pediatricians and physician's assistants and nurses and provide technical assistance across the state. So we really are poised in Georgia to take this to the next level.
Okay, looks like we've got some questions. Representative Gardner.
You talk about ESPERT a couple times. Now I'm trying to figure out exactly what it is, but I find that it is defined in here.
Yes, we do have it
It's
in our...
basically the same as EPSDT. It's another acronym to say the same thing.
It basically is, but of course, the EPSDT is the more comprehensive medical and behavioral health piece.
Okay.
This gives that person the tool they need to dive into what you were saying. Well, what do we do if we've identified an issue?
So there are a lot of tools around.
Yeah.
And some of them are very expensive tools.
And they're not that expensive. We're talking codes that could be set, again, billing rates. There's a range that SAMHSA sets.
What does it cost for a provider to have this tool available in his or her office?
Oh, that is, actually SAMHSA has a free app that they can download on their phone to ask the questions. And then they can bill Medicaid or the private insurance that has it anywhere, whatever we set the rates at. I think it's up to $65 an hour for the full amount, but it'll be in increments of 15 minutes. And so you break it down from there.
Can you do the ESPERT in 15 minutes?
You can, yeah. I mean, I just had a dialogue. I went through those questions, and that's the beginning. That's the screening.
And is there any question in your mind whether this is something that is included in the federal mandate for EPSDT?
It is not. It is
So
because
it's clearly defined in the
right.
And so the misunderstanding about whether mental health treatment is part of EPSDT is something it seems like we need to work on.
Oh no! Now the treatment in EPSDT, if a child is screened and identified, yes, that is under EPSDT. It's that nuance of how do you really get into that conversation? If you don't have a diagnostic in front of you and you're trying to have a dialogue with the kid, and I'm speaking specifically of substance use disorders, that again, you're looking at other manifestations, depression, anxiety, and so forth.
And developmental issues.
And exactly. But EPSDT will take care of that. What the ESPERT tool will do is give you more additional support so that then you can go a little farther on brief intervention around substance use disorders. And then give you the training to refer to treatment for children's mental health or substance use issues.
So when you discuss this with the Department of Community Health and the Medicaid folks, do they have numbers to show maybe from other states? If we're one of the few states that doesn't include this kind of intervention,
we need to crunch the numbers.
We need to know what impact it would have on our Medicaid budget, for one thing.
Exactly. And we just got a study from Colorado, and we're literally just got the study that we're looking over to see how we would put that on, because it's similar in population demographics, but not population amount. I mean, we're at 10 million. Colorado's at 5 million. So how can we extrapolate that to really cost it out for the impact on our Medicaid budget?
So there are
lots of states.
50 minus 12 states that have implemented this, and then you could provide us with data that shows
Right.
that. I think that would be very helpful.
Yes, and we're just, like I said, we've been working on trying to figure out the nuances of this and what all the pieces we have together, and this is the final piece. This billing issue is like the final piece that we need to uncover, and that's what we're going to dig into with Senator Unterman's committee.
Uh-huh.
Yeah.
And is the developmental piece going to be separated from the ESPERT piece?
I don't know the answer to that.
Okay.
I don't know the answer to that.
But, you know, for me, behavioral health includes both of those, so I was just thinking, anyway.
Yes.
Well, it's very interesting. Thank you.
Sure.
Representative Chandler.
I know there would be some legal issues involved with this with public education, but there are ways to get around it, I'm confident. Have you shared this with Marilyn Watson and the other folks at DOE?
We have a coalition that includes all of the, like, Department of Juvenile Justice and Department of Education representatives and all school systems. Even Cobb County, we've got some representatives from up there. We're piloting SBIRT. We've just got another grant really recently in Marietta High School and a school in Dublin. So we're just at the very beginning of trying to see the process. That's what we got the grant for. How do we get the adults to sign off for kids to actually get the next step? How do we, there's in Marietta High School, there's a children's or a graduate success center, and the former principal of Marietta High School has gone over to direct the student success center, and we're piloting SBIRT there with her support. So we're figuring out all those legalities and the processes, as well as how do we then, I think with your question, Representative Gardner, developmental issues, how do we put all that together? So those questions have to be answered. But yes, we have 2 pilots we're very excited about.
That's great.
Yeah.
Because this DOE, of course, has had the information as to what's going on, but this other piece has not been in existence.
Correct.
So this sounds great.
And we haven't targeted children with this particular issue. It's been adults. I mean, every state has been doing adults, and now it's why. And I didn't tell you this at the beginning, but our coalition's called Somebody Finally Asked Me, because what we did was we sat down with kids and said, how do you want to talk about this? And they're like, well, somebody finally asked me. You know, everybody's kind of been like, well, there's a problem, but nobody actually sat down and methodically asked me what was going on. So that's where we're excited that we sat down with kids. They're the ones with the answers.
Thank you.
Well, thank you so much. You've given us a lot to look at and think about, and there may be questions later that some of us want to get back in touch with you about, but I applaud your enthusiasm.
Yeah.
And
I know so many times so many problems are brought, and we know we want to address children's mental health and substance use issues and co-occurring disorders, but what's a tool that could help? And so I really thank you for letting me take this opportunity to give you a tool to put in your toolbox that we can maybe put in others' toolboxes.
Well, that is just excellent. And there must be a beginning, and it sounds like this has some great potential. So thank you so much for bringing it to us today.
Thank y'all.
Mm-hmm. Okay, our next presenter is Dr. Sarah Vincent, a child psychiatrist. And Dr. Vincent, if you would tell us a little bit about yourself, too, when you come, and you can be in either place, whether you want to sit at the table or stand. You've got some, you may need to be there if you need to.
So I do have a PowerPoint for you.
Okay. You may be better there than at the podium, probably.
On the desktop? Okay. All right, so my name is Dr. Sarah Vincent. I'm a board-certified child and adolescent psychiatrist. I have faculty appointments at Morehouse School of Medicine and Emory School of Medicine. I did my child psychiatry training at Emory, and so through that process, I worked at 5 or 6 mental health facilities in the area. I've also done moonlighting work with facilities in Macon and Lawrenceville. I currently work in a Department of Juvenile Justice facility. Just came here from there, actually, in a Grady clinic on the east side where I'm co-located with pediatricians, and also work in a federally qualified health center on the west end. So I've worked in a lot of different settings and locations and have been in Georgia at this point for 5 years.
Excellent.
And so, as I'm sure some folks have gone over as they've spoken to your committee, mental health issues with children are fairly common. 13% of youth aged 8 to 15 and 21% of youth aged 13 to 18 live with mental illness severe enough to cause significant impairment in their day-to-day lives. And so when you look at these numbers, this isn't just capturing kids who may have a phobia or that sort of thing. These are children who have issues that really make it hard for them to function in society, to comply by rules, to get along with their families, to advance in schools the way that they should, to reach the developmental milestones that are really essential to their phase in life. There are average delays of 8 to 10 years between the onset of symptoms and intervention. And as you can imagine, that sort of delay at a critical time in somebody's life can make a big difference. And during that 8 to 10 years, they're trying to go to school, they're trying not to get arrested, they're trying to learn who they are and what their place in the world is. And so that's a really critical delay. And in the United States, nearly 80% of youth with mental illness do not receive treatment. And so sometimes it's not even just a delay, it's that they never actually get the help. And then taking it back to our state in Georgia, so the National Alliance on Mental Illness grades states every few years on how they're doing in terms of ensuring people access to care, providing evidence-based services, adequately funding things that people need. And as you can see, our state has received a D. It also received a D in 2006, which was the last time that grades were given. And that first measure, which looks at very basic things such as the number of programs delivering evidence-based practices, emergency room wait times, and the quantity of psychiatric beds. We received a D on that. And I'll tell you, as someone who works in mental health, that's not at all surprising to me. You know, I've had kids who have sat in emergency rooms over 24 hours waiting for a bed because there are so few opportunities for people. As a child psychiatrist, often in public sector settings, they're not going to pay me to do therapy. They want somebody else to do therapy. But finding a therapist who is trained in trauma-focused CBT and will see this kid with Medicaid can be incredibly, incredibly hard. And so I put this up there just so that you know that NAMI is looking at these things, but this definitely supports my experience and goes along with that, and the experience of many families in Georgia who have been frustrated by trying to access mental health care services for their children. And then just quickly, looking at per capita mental health spending by state, that's us down there toward the bottom of that list. And across the country, there is a child psychiatry shortage. There's a shortage not only because of the few that are graduating, but also because psychosocial problems are so significant and such a big presenting issue. So this is in pediatrics offices, so not mental health offices, not behavioral health offices, but in pediatrics, general practitioner offices. Psychosocial problems are the most common chronic condition for pediatric visits, eclipsing asthma and heart disease. An April 2009 health affairs study reported that pediatricians were more likely than other primary care physicians to be unable to refer their patients to outpatient mental health services. So while it's not great for adults, it's easier for adults than it is for children to be referred by their primary care doctors for mental health services. In Georgia, not only are we dealing with these national trends and what we're seeing across the country, but in this state, we only graduate 6 child psychiatrists per year in the entire state. And with child psychiatry training, you only do that after you've done adult training. So these are people who are trained to do adult and child. They're not exclusively child psychiatrists. And we'll speak about that a little bit later, but that number is in jeopardy of going down even further. We only have 5.9 child psychiatrists per 100,000 youth, and that brings us below the U.S. national rate. And as I said, the raw numbers aren't good, but even with that, a lot of people who are child psychiatrists on paper are doing adult psychiatry at least 50% of the time, sometimes exclusively, because quite frankly, it's an easier system to plug into. And so most of my work has been based in Atlanta, as I mentioned, and I do live here in Atlanta. And something that has been a point of frustration and something that's made it very hard is that we don't really have a major hospital system that is championing that is a champion for children's mental health needs. We all know of Grady as this great place that does a lot of safety net provision, but it really doesn't emphasize children. That's kind of been ceded to some private entities that have decided that mental health is not a priority for them, and so kids are kind of stuck without some major system that is really advocating for them. And so you're left with interfacing with this very broken, decentralized, underfunded child mental health safety net system. We had I'm sorry, I forgot to mention I'm the president-elect and vice president of the Georgia Council on Child and Adolescent Psychiatry. So that's our professional organization for child psychiatrists throughout the state. And we spent most of our spring meeting talking about how difficult it is for people to find jobs who actually want to work with underserved youth, to find salaried positions in the community that allow you to do that on a full-time basis. It is incredibly hard because you have all of these different, pop-up entities that aren't really accountable, that just want you to do contract work and want you to see kids in 15 minutes. And you can't do a good job doing that. And so while on the one hand you have this shortage and people can't get care, on the other hand you have people who want to give them that care, and you don't have systems that allow you to do that, or they want you to see adults because that pays just as much and it's less complicated. And so when they come out, even if that's what they really want to do, it's really hard to do that in a way that is sustainable or that is really simple. People end up having to try to hobble things together if they want to serve that population. When it comes to serving children and adolescents, it is more complex. For psychiatry training, you do an extra 2 years in training in additional to the 3 or 4 years you already did after medical school in general psychiatry to be a child and adolescent psychiatrist. But you're not paid any more to do it. So systems aren't necessarily incentivized to have you take on a bunch of these more complex patients if they're not going to get paid more to do it. And then when it comes to the Medicaid populations, it's not necessarily that the reimbursement is so much lower. It's just that because their lives often are more chaotic, they are more subject to transportation issues, and their phone may not be cut on when you try to give them the reminder call appointment. You do have lower show rates, but you have no way to recoup those costs. And then, of course, dealing with the CMOs, the shifting formularies, and this is something I certainly run into a lot, that formularies can change seemingly on the drop of a dime in the middle of a school year, and it leaves you and families and kids scrambling. And so it is not an environment that is conducive to people wanting to stay once they're done with their training, and you have a lot of people who either end up in the adult system or leaving the state after we only graduate 6 per year. So as you can imagine, the shortage is tremendous. And speaking about children's mental health, it's always important to put things in context. Of course, children interface with so many different systems, whether it be education, general health care, Department of Juvenile Justice, and all of these things interplay. When you have high turnover among DFACS workers who don't know the children, who can't give me a history of what that child has been through or experienced, their care is not going to be as good. And the morbidity and their outcomes are not going to be as good. And so DFACS workers not getting paid what they should directly impacts the mental health needs of children. Cases falling through the cracks, children being exposed to trauma, all of those things are going to increase the need for mental health care services and increase utilization. Something else I've experienced while training at Emory, I worked in an APS school, and I also have worked in settings where people have more means. And something I've noticed is that a lot of times the school resources, the limited school resources we have, are more concentrated in the areas where the parents are better advocates and not necessarily where the children have more need. And so that's something I've definitely seen. I know you've had the Department of Education come and speak with you, and we have this student to school psychologist ratio of 1 to 1,000, right? So that's already a daunting number, but that number is even worse in areas where you have children who are dealing with a lot of psychosocial challenges, where their families are dealing with a lot of psychosocial challenges, and where the school is strapped to begin with. And so there are all these other psychosocial determinants that influence the mental health care of children. And while it's true for adults, it's even more so the case with children, because quite frankly, they're not old enough to come down with some of the more debilitating mental illnesses that we see usually manifest later in life. So things like schizophrenia that normally aren't going to manifest until late teens, early 20s. Most children don't have that. That's not the issue. But things like trauma are great determinants of their mental well-being. Some other psychosocial determinants of mental health: adverse features of housing in neighborhoods. So as I mentioned, I work in a Department of Juvenile Justice facility, so I see incarcerated youth. And I have had children tell me that they feel safer when they're incarcerated than they do at home. That's not healthy. That's going to generate mental health problems. And it is something that is a reality for a lot of the kids that I see. Things like food insecurity, housing insecurity, and poverty have all been shown to be detrimental to children's mental health. And so a lot of times the focus is on abuse, the focus is on domestic violence and exposure to trauma, and all those things are important, but so is a sense of security when it comes to housing and food and knowing that they're going to have a safe place to live. I wanted to talk about trauma just a little bit because when I'm speaking to medical providers about trauma and PTSD, I compare trauma to lupus. We're taught in medical school that lupus can show up in any kind of way in any sort of organ system, that it can negatively affect so many different things, and that is the way that trauma can affect brains, particularly developing brains. And so whether it's that the child is angry, whether it's that they're zoned out, whether it's that they always feel on edge, almost any manifestation of disruptions in thoughts, feelings, or behavior, which is how mental illness is defined, can come as the result of traumatic exposure. So the other ways that mental health issues that are not addressed can manifest in teenagers are, of course, it puts them at increased risk of substance use. You find many kids who are self-medicating, particularly at Department of Juvenile Justice. I work with many children for whom smoking marijuana every day is much more socially acceptable than being sad or talking to a therapist or seeking out formal mental health treatment. And we know that when people start using substances earlier, they're more likely to have problematic use and they're more likely to become addicted. Teenage pregnancy is also something that kids are at higher risk for when they have unaddressed mental health needs. As you can imagine, if it's hard to be hopeful about your future, if it's hard to see yourself as an effective person in society, things like taking birth control so you can ensure that you can stay in school and go on and get a good job just don't become priorities. Academic performance, of course, is adversely affected when you have unaddressed mental health needs, and I saw that in the DOE presentation. They touched on that as well. And I can tell you that a lot of times there are unaddressed learning disabilities, learning disorders that have not been caught. And children, even if they didn't start off depressed, can become demoralized because so much of your day, so much of who you are, so much of the interaction you get with adults is around your grades and how you're doing in school. And so it may start off as a reading disorder, but it may end up as a disruptive behavior disorder because they're getting frustrated and they're acting out and they'd rather cause attention to be paid to anything besides the fact that they can't read and everybody else can. Or depression because they've internalized that sense of being inadequate or being a failure. And then that leads into Department of Juvenile Justice. Now, it's not the case for all of the kids I see there, but there certainly are a high proportion of 7th, 8th, 9th graders who can't read, who haven't had any special education services put in place for them. And so you can imagine that school is not a reinforcing place for them to be. And then also with depression and with trauma, you can see a lot of aggression and acting out behaviors, and those things can sometimes land kids in the juvenile justice system as well. And, you know, as I mentioned, with our state's per capita mental health funding being so low, with the wait times for getting into a psychiatric facility being so long, what often happens is that these children, rather than getting the help they need, rather than getting treatment in a facility, end up in the Department of Juvenile Justice. And I can tell you, they will see a psychiatrist quicker in there than in the community often, because we're located there, whereas in the community it can be really hard to get in to see someone. 70% of the children in the juvenile justice system have a mental health disorder, and approximately 20% have a serious mental illness. So what are some possible areas for intervention? Mental health is something that certainly never occurs in a silo, but governing with psychosocial determinants of mental health in mind, so those things like poverty, food insecurity, making sure that children are safe and that DFACS is adequately funded and staffed to look after and take care of children. And then programs supporting parental mental health. We can do everything we can provide the best evidence-based treatment in that hour a week that we get with them, but we have to send them back home to their parents. And so when their parents have mental health needs that aren't being addressed, or when their parents can't get covered by Medicaid, that makes our job as child psychiatrists a whole lot harder. Incentives for evidence-based therapeutic approaches such as trauma-focused cognitive behavioral therapy, and support of and collaboration with child psychiatry training programs. Right now we have 2. One is in Atlanta, one is in Augusta. Both of them are at 3 residents apiece per year right now. Both of them have had struggles with maintaining that 3 apiece, and both of them are at risk for being even smaller programs. When I trained at Emory, we had 4 a year, and like I said, it's now at 3. So those programs definitely could use some help, and I think there are opportunities for collaboration with them as well. Again, school-based services that are available to the most vulnerable populations, and looking at ways of funding that don't exacerbate health disparities and mental health access disparities that already exist. And then increasing access to mental health care in primary care settings, particularly for children, given that the brunt of children's mental health care in the medical setting is really happening in pediatrics offices. Pediatricians need more support. They need more help. The issue is traditional funding structures really emphasize this one doctor, one patient, we're in the room talking to the patient model, right? I can be much more efficient in trying to address mental health disparities if I'm able to consult to pediatricians on an outpatient basis, if they're able to call me about children that they have questions about. And it's actually a setup that has been effective in a number of states, including some in our region, Florida and Louisiana, that have enacted phone lines so that pediatricians can call mental health providers and get information about how to address the mental health needs of kids before they get to the point where they need to be in an inpatient unit, or before they get to the point where they need to see me. And those have been some really successful interventions. And then funding structures that allow for that coordination piece, that peer education piece to be adequately reimbursed. That's it.
Thank you so much for, if you could wait just a minute, let's see if we have any questions here at all from the committee members. It's very informative statistical information for us. I appreciate that very much. Representative Chandler.
Very sad information, but we appreciate your sharing. You mentioned when you were talking about interventions that there was a need for more school-based services, and of course we all know that. Do you have any suggestions as to what those school-based services might look like?
Well, I think, just the access to children is great that you have in schools, but we need more people there to provide them. But I think having people trained in things like trauma-focused CBT or problem-solving therapy, things that are, kind of more short-term interventions that you can treat, that are manualized interventions, can be really helpful. Most kids don't necessarily need a child psychiatrist. They need a counselor, they need a therapist, they need someone to help support their parents. And so, that piece of it, in terms of really focusing on things that have an evidence base, and then also programs that bring the parents in and support them. That was my challenge in working with schools, is that yes, you have the kid there, but you need the parent there as well. And so making sure that there's space and opportunity for that to happen too, and ways for them to try to get help, which I know is stickier than trying to treat the student, but in order for them to get better, the whole family system can't be dysfunctional.
Representative Gardner.
Well, thank you very much, Dr. Vincent. We're really glad that you came to Georgia. And I'm surprised and delighted to hear that there is a place for a child psychiatrist to actually get training here. It seems to me that it's getting more and more difficult. When Grady's closed Phoenix Hall, for example, I represent Fulton County. And so it became very difficult to get availability of psychiatry services for kids. And the training program, Emory's training program for child psychiatry, pretty much disappeared, or at least the Grady program did. Yeah. I was interested in your discussion with your colleagues about the kind of job you'd really like. I mean, we need to develop the resources that that you all are able to provide. And I've looked at Fulton County and other places where they have, you know, a 5th time here and an 8th time here, and wondering how you manage all that. So what would your dream job look like?
Well, actually, I'm kind of doing it.
Oh, good.
I'm at
You found them.
Department of Juvenile Justice, but it's a smattering of different things. I'm at Department of Juvenile Justice via Morehouse School of Medicine, and I'm teaching the general psychiatry residence, child psychiatry at Asa Yancey, which is a Grady clinic on the west side. And so I'm getting to do that teaching piece. And then I'm consulting to a federally qualified health center on the west side as well, helping them integrate mental health care services there.
Is that the West End?
It's the Healing Community Center.
The what?
The Healing Community Center. So I've started working with them to work with their primary care doctors and develop a system there. And then I have a private practice where I get to do some therapy because I don't get to do it any of those other places. And I think being a good therapist makes me a better psychiatrist.
So your dream job doesn't mean you'd be in one place all the time.
Not for me, but I think for some people, they would like to have a place where they could go and have a salary and get to see kids and know that when you refer a child for therapy, they're going to get good therapy, and that you actually have the ability to, collaborate. Part of the issues with the funding structure being the way it is that time spent as a treatment team discussing patients isn't necessarily reimbursable. But that's a really important thing to do, particularly when you're working with children and families. And so I think for a lot of people, a place where they could see children with the adequate amount of time needed to do a good job doing it, and to be supported in what you're doing. Know that a therapy referral will be to someone who is qualified and who will be there and who isn't going to turn over. Knowing that when a child is brought in by a defects worker, the defects worker knows their history, and being able to have that interdisciplinary meeting and collaboration, I think would be ideal for a lot of people.
Interesting. We've heard a lot about telepsychiatry. The only position I can think of where you would actually be in one place the whole time, if that was the way that worked for you, would be to have a place where telepsychiatry was really available on the spot or close to on the spot. Everybody's heard about the CHOA telemedicine program, that 75% of their referrals were for psychiatry, but they had one psychiatrist and it was a 6-month wait. You probably know more about that than I do. So last year, Emory, in the last couple of years, has come to and asked us for more community psychiatry fellows, I think they're called. Mm-hmm. But what do we do to get them to request residencies for child psychiatrists? I mean, it seems like that's a big need in our state. And you're suggesting people might like to do that if they thought there was a residency that they could survive on and then would be able to get paid it.
Yeah, I mean, I think that the program directors at the existing child fellowship programs would be happy to hear from people about funding and ways to collaborate because, like I said, they're not on solid footing even for those 6 spots. And so I think that they would be very receptive. And, part of the issue is hospital systems get so many spots for training. And as you can imagine, an ENT surgeon resident is going to generate more than a child psychiatry resident, right? And so these are all these things that come into play. But if there are funds that are earmarked for that, I think the existing programs would be very receptive to that. And I know that they are, that both of them make it a point to have part of that training experience include public sector psychiatry.
Well, maybe you can help us make that a priority for Emory. I mean, I think it's important. They, I believe, know that by now, but we need to increase the chorus here.
Yes, I agree. I will join you.
But thank you very much for what you do.
Thank you.
Well, I think that's all of our questions. Thank you so much.
Thank you.
And the many points at which you are hitting Georgia's children is so very important. I'm grateful that you are doing that and that you made this a priority in your day to come here and share that with us is just incredible. So I want you to know that if you need to slip out and get back to work, we support you in that too.
Thank you so much.
Yeah. Thank you so much. Okay, so our last speakers coming up will be Miguel Fernandez, the Deputy Commissioner of the Division of Support Services for the Department of Juvenile Justice, and Dr. Christine Doyle, the Director of the Office of Behavioral Health for the Department of Juvenile Justice.
Thank you. Sorry for the pause. I do want to say before I get started that that was not planned. We didn't plan for Dr. Vincent to be here to speak of, but it very much lines up with some of what we're going to present. So, Madam Chair and representatives of the Mental Health Committee, I'm very pleased to have the opportunity to stand in front of you all and talk a little bit about some of the good work that we're doing over at DJJ. In providing mental health and substance abuse services to youth that are, as has previously been mentioned, very high need, high risk, but oftentimes come to us and we're the first point of contact for services. So I'm really excited about the services that we are providing, and I want to I'm going to defer a lot of that part of the presentation to Dr. Doyle, but I do want to give you generally an overview of what DJJ looks like. So, and Representative Chandler, it's very good to see you. We used to serve on a planning committee for Youth Summit several years ago, and it's very nice to see you. So DJJ is primarily made up of community and facility-based services, but the mental health services that we're providing in DJJ by our staff providers occurs in the facility, so I'll focus my attention on that. We have 26 secure facilities in Georgia, 7 youth development campuses, which are equivalent to the state prison system, which is the long-term placements. Although we're not a prison system, we're primarily rehabilitation and treatment centers. And we have 19 regional youth detention centers, which operate similar to the county jails. Our capacities vary anywhere between 80 to 150 beds in the youth development campuses, and 30 to 200 beds in our local detention centers. Metro Atlanta being our largest center at 200, and then Savannah has 100. We have approximately now, and actually due to juvenile justice reform, that population has gone down significantly. A few years ago, prior to juvenile justice reform, we were up to about 2,400 youth in detention. I've been with the department for 14 years prior to that, and one of the things that I also wanted to say, and I went on to the presentation, is that I am a licensed clinical social worker and certified alcohol and drug counselor, and the work that we're doing is near and dear to my heart and my career. I've been doing it for 25 years, so I'm real proud of what we do. But we still have 1,400 youth in detention on any given day, on average, and we have 850 RYDC beds and 550 total YDC beds. And that's an approximation. DJJ is organized in a very interesting way because we are a child serving agency, but we also have to provide safety and security and law enforcement. So we have 5 divisions in DJJ. We have community services, we have secure facilities, administrative services, operations and compliance, and then my division, which is the Division of Support Services. I know that's a very large picture, but I'll just give you kind of an idea of what I'm responsible for. I have approximately 800 employees under my division. I'm going to skip over behavioral health services. I'm going to speak more about that, but I'm also responsible for the Office of Health Services, Office of Classification, Assessment, and Transportation, and the Office of Training for all our DJJ employees, which is approximately 4,200 employees. Now, the Office of Behavioral Health Services, I used to be the director of that office. I have luckily promoted up in DJJ, but as I have said, I have spent 14 years working in DJJ trying to push mental health services. And if you all recall, we were under a consent decree with the Department of Justice back in 2000, and well, it started actually in 1998, I believe. And when I started working at DJJ, I had been working at Hillside Hospital for 2 years, working child and adolescent services. And someone approached me and said, "Do you want to provide services in a juvenile justice setting?" And I said, "Absolutely, I'm open to any options." And, you know, 14 years later, I'm here, and hopefully we'll be here for about another 14 to 15 before I retire. I will tell you that I feel like we provide a great great comprehensive psychiatric, mental health, and substance abuse services to the kids in our care. We have challenges. We have a lot of challenges. We have kids with very high needs, and we have kids that have, as was described by Dr. Vincent, and as I said, I did not plant that in front of you all today, but some of those kids that are being overlooked by some of the other systems, not diagnosed and then brought to us, and that's when we begin to treat and provide them services. Trauma-informed care, we're going to describe a little bit on the things, our growth, even in assessing and diagnosing that. And so, without further ado, and I can't tell you how proud I am, Dr. Doyle and I have been actually working together almost the same amount of time, 14 years. And Dr. Doyle and I have kind of grown up in the system, and she is absolutely wonderful. She is the chair of the interagency directors team, and who reports out now to the Behavioral Health Coordinating Council, where I oftentimes see Representative Dempsey. Dr. Doyle is a great asset to DJJ, and I'm going to ask her to come on up and talk a little bit about the services that we are doing in DJJ. So thank you very much for the opportunity, and Dr. Doyle.
Thank you. Thank you, ladies. Good morning. I appreciate the opportunity to be here with you today. As Deputy Commissioner Fernandez mentioned, our office grew out of the Memorandum of Agreement with the Department of Justice that was established back in 1998. DOJ required DJJ to establish a behavioral health office to oversee staffing and training for mental health service delivery, screening and assessment of the youth in our care in secure facilities, treatment planning and service provision, alternative placements for youth with severe emotional disturbances, and I'll talk a little bit about more that in some depth later, suicide prevention, and quality assurance and monitoring. When DOJ made this requirement of DJJ, there was one full-time clinician in one facility statewide, and that was it. Sometimes center directors would create partnerships with their local mental health systems or a private practice or what have you, but we really did grow the Office of Behavioral Health Services from the ground up. So flash forward from 1998 to where we are today. OBHS provides oversight to all of the mental health and substance abuse services provided in secure facilities, as well as general counseling, case management, and sex offender treatment. Every secure facility has master's level clinicians on staff, psychiatrists, psychologists, a registered nurse, and our YDCs have substance abuse counselors on staff. So we do have a full treatment team in all of the secure facilities. Our master's level clinicians are full-time state employees. Our psychologists and psychiatrists are part-time employees or contractors directly with the state. And our registered nurses are also full-time employees. There are many reasons why a youth might be selected to receive behavioral health services if they're in one of our secure campuses. Predominantly, obviously, if the child is experiencing and displaying symptoms of a mental health disorder. So suicidal thoughts, severe self-injurious behavior, psychosis, particularly ongoing psychosis that's not related to intoxication. Often when we receive a child from the community into an RYDC, the child will have used some sort of substance prior to their admission. So we have to give the child some time to detox, if you will, for us to get a clearer idea. I think Dr. Vincent spoke fairly eloquently on what she's seeing on the ground in Metro. Mood problems, and we'll talk a little bit more about the breakdown of the different diagnoses that we see in our system. Anxiety disorders. When people think of anxiety, it's typically panic attack, phobias, I don't like spiders, I don't like bridges, but PTSD also falls into the anxiety disorder category, and that is the predominant diagnosis in the anxiety category for our youth. And of course, a history of trauma. Nationally, 90% of youth in secure juvenile facilities have experienced at least one trauma, and approximately 85% would qualify for a diagnosis of full or partial PTSD. I see no reason to believe that Georgia's children are any less traumatized than children anywhere in the rest of the nation. If the youth requires psychotropic medication, they would be on the mental health caseload and not only receive services from the psychiatrist, but also ongoing services from a master's level clinician. Really, our master's level clinician is our bedrock of our treatment team. And as you'll see in just a moment, psychotropic medication is a significant but not the most significant component of our treatment. The treatment team can also just determine the kid needs the support. You know, perhaps they are not evidencing enough of any particular type of symptom to say the child needs this diagnosis, but it's clear the child is struggling and needs help, so that they may be maintained on the caseload in that case. Also, if the child was receiving services in the community at a different facility and there's reason to believe that without those supportive services the child would decompensate, those services should be continued. We also maintain youth who are being evaluated for competence to stand trial on the caseload for the duration of that evaluation at minimum, and if the child is referred to the Behavioral Health Placement Review Panel, and I'll talk a little bit more about what the panel is in a moment. So how does a kid get to services in DJJ? Well, the first thing is we screen them, and we screen them a lot, because kids are dynamic. Things change for them. Any child admitted to a secure DJJ facility is screened for mental health and substance abuse within 2 hours of their admission. And for the last several years, we have hit 99% of that time frame goal. So when we say we're doing it, we truly are doing it. We screened not quite 12,000 children last year, and of those, 58% of them hit a cut score on the screening that required evaluation and assessment by a master's level professional. So a child can also request services themselves at any time. So even if a child comes in at the beginning and answers no to all of the screening problems, and we see this particular example quite a bit, the child can then put in a help request a day, 2 days, a week, a month, what have you later. And the one that we see an awful lot is, I was on medication and I lied to you about it because I didn't want to feel like I had to take medicine, but boy, I'm finding I need it. And the second one is, I'm having nightmares. I'm having flashbacks to traumatic events that I experienced on the street. My friend was killed in front of me. My father was killed in front of me. And those are probably the two biggest ones that we see. But a child can request services for any reason. Also, a parent, caregiver, DFACS worker, staff person, anyone who sees a child struggling can submit a request on their behalf. We offer crisis management services to all children in secure facilities, not just on the mental health caseload. So we have 24-hour availability of master's level clinicians. They are available by phone and if necessary are required to be in the facility within an hour if needed. We say within an hour because in our rural areas sometimes clinicians drive quite a ways. For instance, our full-time mental health clinician in Dalton drives from Marietta. So you have to give them the time to get there. We also have psychologists and psychiatrists available on call 24 hours. So if a child needs an emergency dose of medication, something of that nature, we have the staff available to do that. We also offer additional interventions of suicide management plans and special management plans, which are really specialized treatment plans that could be on top of a treatment plan or in place of a treatment plan for a child who is not presently on the caseload, that gives clear and specific direction to a juvenile correctional officer of how to work with that child. So it's a piece of paper that the JCO can actually keep in their pocket and pull out and look to see, well, what does this child need? How can I best interact with them? So mental health assessments are required within 72 hours for referral for the assessment. So say if a child's referred from screening or if there's a help request within 72 hours, no exceptions for holidays or weekends, 72 flat hours. Child must be seen by a master's level clinician. In addition, all children who are admitted to a long-term facility, a YDC, receive a comprehensive evaluation that includes a youth interview, parent interview, comprehensive records review, and that evaluation has to be completed within the first 10 days of the child's placement. In addition, we do trauma screening on all youth who are admitted to a YDC as part of that YDC needs assessment. Trauma screening is available in the RYDC, but only for those youth who answer yes to a trauma screening question or who, in the course of their assessment, disclose that they have had traumatic events. In addition, any child who's placed on the mental health caseload has to be seen by a psychologist or psychiatrist within 10 days of being placed on the caseload. Any child who is on psychotropic medication or has been within the previous 2 months is automatically referred to the psychiatrists, and all others are referred to the psychologists. And this is where we talk about psychotropic medication. 49% of the kids that we treat on the mental health caseload are on psychotropics. And I like to point that out because that means 51% of the kids that we're providing services to are not on psychotropics. So talk therapy of some time is the intervention that is being provided to the majority of the children that we serve. So I know there have been frequent concerns that medication for compliance, medication for management, we don't do that. So, mental health services. What services are available for every youth, regardless of caseload status? Obviously, suicide prevention, crisis intervention, special management planning. For youth on the mental health caseload, in addition to the psychiatric services, individual therapy, group therapy, medication management from the doctor, treatment planning. And here are some examples of some of the evidence-based practices that we provide. SPARKS is near and dear to my heart. Structured psychotherapy for adolescents responding to chronic stress. It is a group-based trauma intervention specifically developed for children with juvenile justice or involvement or high risk for juvenile justice involvement. And one of the nice things about this is, if you'll notice in the name, it doesn't say the word trauma anywhere. That's important because for a lot of our kids, they don't know they're traumatized. If they come from a violent neighborhood, Dr. Vinson mentioned that some of the kids will come in and tell her that they feel safer in our centers than they do at home. That's just home. We recognize that that's not a healthy environment, but that's just the water in which they swim. So they have very much normalized that. And if you approach them and say, I'd like to offer you trauma treatment, I don't need trauma treatment, I'm not traumatized. But if we come and say, hey, look, we'd like to offer you this group for stress. You got some stress? Well, of course, everybody has stress. Well, come on then, let's have this group. We're going to help you with your stress. And the children are never required to disclose a traumatic event, but 90% of the time through the course of the group, they do end up, A, recognizing, wow, what has happened to me really is trauma and really has had an impact, and B, there's something I can do about it. There's something I can do differently. We also offer trauma-focused cognitive behavioral therapy, which was referenced before, which is an excellent model. It's an individually delivered model. New Freedom Treatment Program, which is a cognitive behavioral therapy-based manualized treatment that really has something for all of the disorders. So we have a map, if you will, that's mapped to all the different diagnoses that clinicians can go in and start clicking around, and it will pop up the treatment resources specifically for that child's needs. We also offer a group called EQUIP, which is a treatment program specifically for behavior disorders. This uses positive youth culture, which may sound odd in a secure juvenile detention facility, but it's really an excellent place for the kids to learn those skills because they have adult reinforcement available to them at all times, which isn't necessarily the case in any other environment for them. We also use the EQUIP model to help them develop anger management skills, social skills, correct their thinking errors, and improve their moral reasoning. And for our substance abuse treatment, we offer the 7 Challenges model, which incorporates group and individual treatment. So a statistical overview for the fiscal year 2015, you can see that we admitted 548 youth to our long-term campuses and 11,270 to short-term campuses. Of these, 49% in the YDCs received ongoing mental health services and 42% in the RYDCs. Really a good reason for the lower number in the RYDCs is the rapid turnover of the children. So they may be there in time to receive their screening but then released at court before they can have their assessment, or be assessed but released at court before they can be seen by a doctor. Whereas in the YDCs, we do have the children for longer periods of time. In addition, in the YDCs, we have kids as they're becoming older, so mid-teens, late teens, even early 20s. And these children tend to be at the age of highest risk for the onset of a major mental illness. So even if they did not have a diagnosable mental illness or had a more minor disorder when they came to us, we are likely to see them at their first onset or at their first break. So a quick overview of our diagnoses, and these are multi per kid. Usually it is the rare child who has only one diagnosis, so these will not come to 100% because several children have more than one. To no one's great surprise, substance abuse related disorders are our primary diagnosis. Conduct disorders, attention deficit disorder just about ties with mood disorders. We have a lot of depressed kids in DJJ. Anxiety and trauma is our next. Almost 30% of the children that we serve qualify for a full diagnosis of PTSD. We are treating more children for trauma than that because we will also treat children with a partial diagnosis or children who are subdiagnostic but who are experiencing symptoms that are severe enough to require treatment. Impulse control, relational, abuse, neglect, separate from trauma but wraps together, and then you see some of the smaller ones. And thought disorders, as you might expect, again, because we are having children at their age of peak vulnerability for a first onset of major illness. For substance abuse services, 33% of the kids that we screened at the RYDCs admitted to using an intoxicant within the past month. 53% of the kids at the YDC, and of our YDC admissions, 37% were identified with a use or abuse issue that was serious enough to require residential treatment in our residential substance abuse treatment units. So, specialized treatments. Earlier on when we were talking about the MOA with DOJ, we talked about the fact that one of the requirements was that we had to have alternative placements. That's really challenging with a YDC kid to call up a PRTF and say, hey, you want a kid? Oh, by the way, he's committed to us and we have to keep him. No, that's not going to work. Thank you for your time. So we had to develop something internal for these children. What we developed were these. The intensive treatment unit, I'll actually talk about that last. Our mental health units were the first 2 units developed. We have a 14-bed unit for females at our Macon YDC and 20 male beds at the Augusta YDC. These are beds for kids with extremely high mental health needs who need a residential setting. The treatment providers in those campuses have been trained in additional modalities. They are more richly staffed, so there are more services available for those kids. We also offer shelter care services for kids who might not have particularly high mental health needs per se, but might be at risk for victimization or vulnerable for whatever reason. Medical vulnerability, we did have one child who was in a car accident and had a metal plate in his head. We have several children who are lower cognitive functioning and at risk of being bullied by their peers. The shelter unit serves their needs. In addition, we have the residential substance abuse treatment beds that we just mentioned. We have 25 beds at our Sumter YDC, 20 beds at our Atlanta YDC, and 20 beds at our Augusta YDC. And the program typically is of 6-month duration, so these roll over about once a year, and we can serve approximately 130 children in the residential units. That being said, substance abuse treatment is available to all the children in the YDCs. The children who don't qualify for a residential unit get them on what we call an outpatient basis. So they live in any particular unit, and then they go to their groups and their individual treatment, but they do receive the same treatment program of 7 challenges. That's also how we handle the young ladies at Macon who require 7 challenges. Since there aren't really enough of them to comprise an entire unit, they receive them on an outpatient basis. The intensive treatment unit is coming up on its first birthday. We identified a need to treat severely behaviorally disordered kids who also had high mental health needs in our system, and did some really intensive research to find some evidence-based practices to do this, and found one. So we took ourselves up to Wisconsin, where the Mendota program for behaviorally disordered youth lives, and they were wonderful. We spent 3 days and saw their unit, interviewed their staff and kids. They gave us all their materials, and we brought it back and kind of Georgia'd it up. So we have a 30-bed unit at the Milledgeville campus, 20 treatment beds, and 10 what we had initially started calling the step-down beds. And when the kids started getting ready to transition, they said, no, this is a big success for us. This is our step up. So we have 10 step-up beds per our children. The kids receive intensive trauma training, intensive equip training, as we've just discussed, and intensive life skills training. And they can be referred from units all over the state. We received our first children at that unit on January 20th of this year, and the Step Up unit is preparing to open the week after Thanksgiving. So finally, the quality assurance piece that was required by the MOA, we have managed in large part with our electronic record. DJJ has an extremely comprehensive electronic youth record, of which the mental health is a portion of that. So we track all of our documentation in JTS, Juvenile Tracking System. That allows us to assure timelines are met, to monitor and correct when they are not, and to go in and assure the quality of services that are being delivered, because we have the option of reviewing all of those. And it really helps us get ahead of problems when we start to see them emerge, rather than coming in and finding that something has blown up. At this point, we are about 95% paperless, and our goal is to be 100% at some point. We're down to those things that require multiple signatures from multiple people at different parts of campus. We haven't quite figured that piece out yet. So, challenges that we're facing, I think this will probably echo my colleagues who have presented earlier. Treatment resources to link the children to in the community are limited, and in rural areas they can be non-existent. The higher the child's needs, the more difficult it is to find something to link the child to. And the older the child is, the child and adolescent behavioral health system stops at the age of 18, and theoretically the adult system begins at the age of 18. But those children who are 17, 18, 19, up to 22, 23, don't have a good place in either system. They're neither fish nor fowl nor good red meat. And finding somebody who can treat those very vulnerable young people as they're coming out and assuming their place in the adult world can be very challenging. We also have a real problem with residential provider bias against our kids. Dr. Vinson mentioned, and I wish I had the time to talk to you more about trauma, that's near and dear to my heart, but often traumatized kids act like conduct disordered kids, because that's how their trauma evidences itself. Major depression for us may look like very sad and droopy and low energy. For kids, it often looks angry and irritable, and again, very much like a behavior problem. So a lot of residential providers are loath to take DJJ children. They have what I like to call conduct disorder goggles. And regardless of whatever else is going on with that child, we can demonstrate they have a major depressive disorder and severe trauma problems, and they look and they see behavior, whoops, nope, it's conduct, we don't want them. We also have similar challenges with children with serious mental health problems and a diagnosis on the autism spectrum. The mental health providers are pointing at the DD folks are pointing at the mental health folks, and nobody is really serving the child. And then finally, lack of qualified staff to recruit and retain, especially in rural areas. There just is a dearth of providers to recruit, and especially psychologists and psychiatrists. Our Sumter YDC took 14 months for us to recruit a psychologist, and we did national advertisements, statewide mailings in Georgia and Alabama. We weren't sitting on our hands. We were being as aggressive as we could, and it still took a long time. So that's a quick overview. Can I answer any questions for you?
It was an excellent overview, too. Thank you. This helps us so much, this information that y'all are giving us to work on the report we are going to prepare shortly. So are there any questions from the committee members? Representative Chandler.
A quick question. What is the average stay in the regional programs?
About 3 weeks is fairly typical. The children that go out at the front end go out very quickly. Obviously they're mandated to have a 72-hour detention hearing, and a large percentage of them are released at that hearing. For those children who are retained at their hearing, it takes 2 or 3 weeks typically for them to get back on the calendar. Now, of course, we're serving kids who are charged in superior court and might be there 12, 18, 24 months, or kids who are being evaluated for competence. And that system can be very slow to produce the evaluations. But I would say on balance 2 to 3 weeks.
I wondered why there was not a substance abuse counselor in those facilities. Is it, please?
We do provide substance abuse services there for children who are on the mental health caseload. Their individual counselor addresses their substance abuse treatment needs during their treatment sessions. For kids who aren't on the mental health caseload, our juvenile detention counselors are trained to provide basic substance abuse education and intervention. Our concern about providing a deep, in-depth program is, again, the RSET is a 6-month program, and if we're going to have the child 3 weeks, we don't have time to do the real in-depth treatment, but we do try and address their needs. And we do try and do basic education with the at-risk kids, hoping that those that have not already started or progressed too deeply into use, that we can help nudge back out.
Great. Thank you.
And I'll add, we're also looking right now, we have a federal grant that is giving us some funding to possibly look at doing some brief intervention, but with the intent of doing brief intervention and referral out to 7 Challenges programs out in the community. We're in the process of coordinating training for the spring, and so hopefully we'll have that as an option, but the quicker that we can move them out into the community to provide the services there, the better. We don't want them deeper into the system. So. But we do recognize that we will have some.
Good. Thank you.
Thank you. Representative Gardner.
Thank you. It's a very impressive, comprehensive system that you all have built. I'm impressed. We all know what precipitated this change, which was, of course, the Department of Justice coming in. So they have come in to look at the adult mental health and developmental disability issues. They've come in and really forced our system to pay attention to mental health and juvenile justice. And then we have the children that we're trying to keep out of your system. I mean, are there people circling around threatening to go to DOJ and force our state to provide the services for children that, I guess...
All this DOJ stuff is all on the GNets.
Anyway, that's sort of my question. The specific question had to do with the electronic tracking system. Where does that information go? I mean, how can you share that with people that your kids may go to in the community, or do you get information from previous evaluations that are useful to you? Does your system talk to other systems?
We try.
Yeah, I know.
For children who are coming to us, we do our best to get previous treatment records, send releases to parents, ask them to send them back to us. We have nurses waiting at visitation with releases saying, here, would you please sign this? Our juvenile probation officers are really good at sniffing out and tracking down prior evaluations. So we do gather as much information as we can and use all of it, obviously. We also try and communicate to our providers as much as possible. We have a document that auto-generates for every child who is on the caseload, and nobody has to do anything. JTS pulls it all together, and it can be printed up at any point in the child's stay, and it has their diagnosis, if they're on any kind of medications, what they were receiving treatment for, what sort of treatments they've received, what they've completed, and we send that out with the child. The master's level clinicians are the ones trying to help set up the appointments and giving referral information. So we do try and make sure that information is provided to our community partners.
So to create the continuity of care that
exactly
you're trying to achieve.
And it can be so challenging because with children, everything looks irritable. So if we've had them for a long enough period of time to really do some of that teasing out, it just wouldn't serve the child for us not to pass that on and say, yeah, he looks irritable, but we really found out it's this and this and this, and this is what's worked for him.
Well, you've done a marvelous job of creating, it looks to me like a system with continuity, and maybe you can be a model for some of the other parts of our system.
Thank you.
We have prepared ourselves electronically. I'm sorry.
Come up to the microphone so we can have this forever.
Sure, absolutely. Since we are, we've participated in the Georgia Health Information Network database development. One of the things that we have are done is we stand prepared to do that. Now, I will say on the electronic health record side, we have built a portion of the electronic health record, but we're shortly up and coming to the requirement in the Affordable Health Care Act to be ready to exchange information by the end of 2017. So that is definitely one of the global needs that we'll have to be able to do. We have prepared our existing database to be able to communicate with Georgia Hens, and we are actually able to log in and pull information from Georgia Hens. But I think all the providers are probably going to, there needs to be a focus in the next couple of years to get us to the point where we are freely exchanging information electronically with some of those agencies. Now, there is some concerns that we have around their involvement with the legal system and how that is shared inside the electronic health record environment. But I think that there's a quick fix to that. It's just a matter of changing the label of the provider that entered the information into the system. But outside of that, we stand prepared, but I think that the state probably needs to look at how all the state agencies are going to continue to feed that information so that the information is freely available. So
is that happening? Do you know, is that happening at a...
well, my understanding is that Georgia Health, and I don't want to speak for GTA or Georgia Health Information System Network, I believe is what it was called, the Georgia Hens, but I know that is something that that there has, the state agency representatives for technology and information systems have been meeting and discussing that. But we're kind of getting close to about a 2-year window before all of that needs to roll out. So under the Affordable Health Care Act. So.
It's very interesting. Thank you.
And if I may elaborate, I've been involved in some of those meetings, and I and all of my colleagues do have login information, so we can pull. Obviously, we're limited to only those who are pushing. So right now, CHOA is providing information, but a lot of the private providers are not. But that's part of the process. As DC Fernandez was saying, the child's legal protection to not disclose that he was juvenile justice involved is going to be one of our biggest challenges, because all of our information has DJJ stamped all over it. So then how do we provide the information without also violating that child's confidentiality for his legal status? And we're working that out.
We hope you can work it out.
We will. Thank you.
Cut myself off. Thank you so very much. Appreciate that. We have certainly taken in a great deal of information this morning, and I thank each and every one of our presenters for that. Our next meeting, which right now may be our final meeting, will be Wednesday, November 18th at 10 a.m. in this exact same spot. So I look forward to seeing many of you here then. We are open to ideas and questions as you step away. If something else comes to mind that we need to be aware of, we do have a report that is due December 1, and it's our goal to try to meet that deadline. So do not hesitate if you have some information that could help us. Thank you so much. Y'all have a good, safe day.